come and honor the chairs. We request Dr. Banerjee, our medical director, Dr. Rahul, Dr. Sonali Sarkar. So let me take the honor to introduce the speakers who are there in the dais. Dr. Anish Banerjee is our medical director and also is one of the director of the board. Mr. Ashish Bhattacharya, our CFO, orthopedic surgeon, and Dr. Sonali Sarkar, our senior cardiologist. So we are expecting a crowd, also eminent consultants and the other eminent doctors to be present in a short while. But as because we have scheduled this program from 7:30, we have waited almost an hour. So we think that we should not spend more time in waiting. Let us start, and we all want this session to be more interactive, a more academic session. Usually what happens in the CMEs, and we'll be also sharing the vision of Bengal Faith after the journey of 2.5 years, where we want to go, where we want to reach in next 1 year, 2 years, and of course in 5 years time. We have established this center as a wonderful center of excellence of multi-speciality. Now we want to add on much more super specialty services. The days will go on. We'd like to hear more from our medical director, Dr. Anish Banerjee, and also will be interacting with you with various aspects of different subjects, the specialists who are there and the speakers who are there already in the dais. So I am handing the mic to Dr. Banerjee. Thank you.
Medicare Hospital, as rightly Sanjay said, but we had a goal, sirs, to build a hospital for those patients who need care most and without which they would die. As an administrator, as a physician, I am very happy to say and note a few things. This hospital has had one of the lowest hospital-acquired nosocomial infection rates in the country. The HAP rate, the VAP rate, or catheter-associated are maintained very stringently by us. The parameters have been set and care so far is protocolized thanks to the wonderful team of nurses, medical officers, and the emergency team led by my colleague Dr. Purba. Protocolized care is something that we have always taken up as our mantra, and that is how it is till date. We have started and escalated from point to point. Almost a year back, we started a catheterization laboratory. We have always aspired to start small. In the list of firsts, state-of-the-art microbiology laboratory has recently been started about that. Sphingomonas possimobilis. We found plenty of Sphingomonas possimobilis in hospital-acquired infections coming to us in Burdwan, and probably a strong contender for the service of cardiology. We have pledged and will.
Being it should be rapid in onset, short in duration, and spontaneous complete recovery. What are the other conditions that are incorrectly diagnosed as syncope? It is a common presentation in our emergency department in our general day-to-day practice, and there are many other conditions that are misdiagnosed as syncope. These include epilepsy, metabolic disorders like hypoglycemia, hypoxia, hyperventilation, intoxication, transient ischemic attack, and other disorders like cataplexy, depressants, or volume depletion due to hemorrhage, diarrhea, vomiting. In cardiac syncope, it's cardiovascular. There's arrhythmia as a primary cause. It may be bradyarrhythmia like sinus node dysfunction, AV conduction system disease, or an implantation may have structural heart disease. Like cardiac valvular disease like aortic stenosis or pulmonary stenosis, acute myocardial infarction, hypertrophic obstructive cardiomyopathy, cardiac masses like atrial myxoma, pericardial disease or tamponade aortic dissection. We advise still testing for recurrent falls or syncope where the etiology is not clear. It is known as adaptive test where I am not going into the very details of these tests.
Today I am going to speak or throw us some amount of light on role of devices in the management of sudden cardiac arrest. So mainly, what do you mean by sudden cardiac arrest? So cardiac arrest or cardiorespiratory arrest or cardiopulmonary arrest, whichever term we use, is the abrupt cessation of normal circulation of the blood due to the failure of the heart to contract effectively, which leads to inadequate cerebral perfusion, ultimately unconsciousness, no breathing, no pulse. So what is sudden cardiac death? Sudden cardiac death is actually abrupt cessation due to cardiac arrest, and survivors can be either resuscitated or a spontaneous reversal that we call as sudden cardiac death survivors. According to the modern definition of sudden cardiac death, the cardiac arrest which occurs within 1 hour of the onset of acute symptoms, or patient whom we see that he was with a major cause of sudden cardiac arrest leading to sudden cardiac death. So the chain of survival, the most important thing is early access, start early CPR, early defibrillation, and finally the ACLS protocols. So time to defibrillate, of this the sudden cardiac death, 80% or more than 80% of the death are due to arrhythmias, of which the most common are the monomorphic VT, followed by a polymorphic VT or VF, and then the pulses, electrical activity, and finally cardiac damage, which cannot be corrected just by pacing, but we need a CPR or other defibrillators to reconvert them. Minimal symptoms have only 20 to 30% risk. And there has to, in short, isolated episode of VTVF provides defibrillation or cardioversion either by an anti-tachycardia pacing mechanism or by giving shocks, provide pacing for bradycardia if required, and provides a record of patient arrhythmic events whatever is going on. While just a study, we can get the whole study of whatever has happened with the patient in that.
Today's work is preventing arrhythmic strokes in Brugada in cases who cannot afford ICD.
So quinidine do have said that in type B type it can be somewhat helpful, but in type A it has been seen if they don't undergo with means cannot be controlled, and moreover these drugs are said to have some side effects also, like mainly prolongation of QT and all, and in that cases it may not be very safe.
Once again, on behalf of Bengal Faith Hospital, I would like to thank. And the topic is microsurgery and overview.
Not microsurgery, microneurosurgery.
Microneurosurgery, yes sir. Thank you.
I have not prepared this talk for a neurosurgical audience. It is for all doctors, so I'm going to keep it very short. I'm going to show you some pictures, and I would like to have the interactive session to be little more than the amount of time I take for me to deliver this lecture. I'm sure going to be very quick, and I'm going to talk extempore. I'm not going to go into any details. So this is the photograph of a very senior neurosurgeon. His name is M.G. Yashagir. He is considered to be a pioneer. All neurosurgeons know him, so this is only for hospital in Bombay. And Dr. Sengupta woke up from his sleep and went to the corridor and saw the manager of the hotel running around. He asked the manager, what is the matter? I mean, he said that Dr. Yashagir honking all the time, but he is not used to all that. So, very strange story. I mean, I didn't know about it till Dr. Sengupta told me. And this is about neuroanesthesia. I don't think I should go into any detail. Dr. Garg here in the audience anesthetized two of my patients today. One was a large intradural extramedullary spinal tumor, most probably a schwannoma, extending from the foramen magnum up to C6. A huge tumor. I mean, all the credit goes to our neuro anesthetist colleagues. See, the principles of anesthesia are typical neurosurgical operating room, called operating theatre in India and on colonies of Great Britain. People in America call it an operating room. And this is the operating microscope. As you can see, the operating microscope used in neurosurgery has to have a lot of mobility. And here the operating microscope, which is shown, common approaches and positions for microneurosurgery. This is a typical patient. What you can see attached to the head is called a 3-pin fixator, or people call it a Mayfield. It is used to fix the head rigidly so that there is no movement during while we operate. I don't have pictures of a Mayfield. We have one in the theatre, so someone.
Sanjeevi, and he has completed his MCH from Madras Medical College and former consultant of Apollo Chennai Hospital. Right now he is a neurosurgical consultant in Bengal Faith Hospital, Burdwan. So I'd like to request him to please come on the dais.
First of all, I would like to thank to Bengal Faith Hospital for giving me an opportunity, especially our medical director, Dr. Anish Banerjee, and head, Mr. Sanjay, and beloved my respected senior doctors, my colleagues, and family of Bengal Faith Hospital. So my topic, allotted, is difficult neurosurgical cases. So in neurosurgery, there is no difficulties, all cases are difficult. So even small shunt also will cause more amount of complications. So rather than calling it as difficult, challenge in neurosurgical cases. Next. So why it is difficult and challenging? Because of the location of the tumors, location of the aneurysm, AVMs. If it is more in deep, so it is challenging or difficult. And usually tumors almost invading the cranial nerves, compressing the cranial nerves, that can cause more morbidity to the patient. Then vascular encasement and the consistency of the tumor. It was operated with me last Saturday. So it's a 50 years old female, known case of olfactory groove meningioma. She was diagnosed in 2020, but the family members were neglected and she took only the native treatment, that the homeopathic treatment for the past 2 years. And last week she got admitted in some government hospital with a GCS of 3. Next. So the attendants came and they consulted with us. So just bring the patient. If anything now we will do like that. We give the assurance. Patient was brought to emergency with the GCS 3. The EMO emergency department has done a wonderful job. They intubated and resuscitated. The metabolic parameters, everything was corrected, and the patient motor movements came to M2 to M3. So by the time I talked with the patient attendants, sir, if you are allowed, this is the brain surface. This one is the superior sagittal sinus, which was divided. Next. So after retracting the frontal lobe, you can see that its tumor was highly, it's a solid-like consistency. It was highly vascular. Next. So initially that soft portion was using bipolar. We removed that hard portions. I used a drill to remove all the tumors. Next. So picture is not clear. I almost removed all the tumors. The black one was next. So this is a tumor size. So I have removed almost 99%. I have removed. It's like a ball. So this is almost 75%. The rest of the things I used to remove as a piecemeal manner. Next. So as the prognosis was poor, I planned for there's a difficulty in extubation. So I have done tracheostomy after the surgery. Next. So this is a post-operative scan which shows complete removal The black part what you are seeing is the edema, which is preoperatively present. Next. So this is a post-operative scan showing almost complete removal of.
Okay, sir. Okay, thank you very much. Thank you once again on behalf of Bengal Faith Hospital. He is a senior consultant of Bengal Faith Hospital in the Department of Urology. And the today's topic is practice of andrology. Thank you very much.
When in case of sympathetic activity, more the sympathetic activity, more will be the erection, and parasympathetic activity leads to erection, and in case of more sympathetic activity, there will be erectile dysfunction. Coming to the etiopathogenesis, this is the classification of ED, broadly classified into organic and psychogenic variety. Among psychogenic, it is classified into generalized and situational variety. So generalized is among to all the partners and all the objects. In case of situational variety, there will be erectile dysfunction with specific partner or specific objects. The organic variety is divided into 4 types: vasculogenic, neurogenic, anatomic and endocrinologic. Among vasculogenic, they are classified into arteriogenic, cavernosal and mixed variety. The psychogenic variety, previously thought to be most common, that affect 90% of important men, but now they are actually mixed variety. The 2 possible mechanisms have been proposed to explain the inhibition of erection in psychogenic dysfunction. The first one is direct inhibition of spinal erection center by brain as an exaggeration of frequent finding in important population. The role of testosterone is to enhance sexual interest, increase the frequency of sexual acts, traumatic injury to tunica albuginea by the benign fracture. This can impair the compression of subtunical and emissary veins. Structural alteration in the fibroelastic component may also lead to venous leakage and ED. Loss of compliance of benign sinusoids may also be associated with increased deposition of collagen and decreased elastic fibers. And they are hormonal influences and evaluate the vascular status of penis directly. The vasodilator used are alprostadil alone or mixture of phentolamine and papaverine, which is also called bimix, or mixture of all 3, that is called trimix. Now duplex ultrasonography, most commonly performed test for the erectile dysfunction. It combined the CIS and it measured the blood flow